Welcome to the University of California, San Francisco knee replacement preoperative informational video. My name's Lisa Hartmeyer and I'm a nurse practitioner in the Division of Arthroplasty. We're going to go through these topics one by one, starting with the anatomy of the knee, understanding how knee replacement surgery happens, anesthesia, recovery in the hospital, pain management, physical and occupational therapy, risks of surgery, incision care, preparing for surgery, discharge planning, contact phone numbers, and prescription instructions. We're going to start with the anatomy of the knee. The knee is made up of your femur, your tibia, and then your kneecap or your patella. At the ends of these bones, it should be covered in a smooth cartilage, which serves as the cushion. You also have 4 ligaments in your knee: the medial collateral ligament on the inside, the lateral collateral ligament on the outside, and then inside your knee you have the anterior cruciate ligament and the posterior cruciate ligament. These keep your knee working as a hinge joint. In arthritis and other conditions, that cartilage wears down and you have a painful knee joint because the bones get closer together. You can also have osteophytes form, or bone spurs, and cysts that form at the end of the bone. All in all, this causes a very painful knee. Understanding how knee replacement surgery happens. The surgeon will make a 4 to 6 inch incision over the front of your knee. He'll then go in and shave down the femur to fit the prosthesis. This is what the femoral component will look like. It's made out of cobalt chromium and it will cap your femur. This will be cemented on. The next part of this process is the surgeon will go in and shave down the top of the tibia. This is the tibial component. In between the femoral and the tibial component is a piece of highly cross-linked polyethylene. This is that plastic spacer that's going to provide the new cushion in your knee. It'll look like this. The surgeon also goes in and he shaves down the back of the patella and places a plastic piece similar to the one here. This is called a button and will serve as the space between your kneecap and the femoral component. This is what a total knee replacement will look like when it's completed. This is a completed knee replacement. The example on the left is a patient before knee replacement and then afterwards. You can see the white area here is the metal piece. In between is a piece of plastic. You cannot see that on X-ray, and then this is the tibial component. Understanding knee joint replacement surgery. Your knee implants are cemented, and you will be able to put full weight on your knee after surgery. Anesthesia. When you arrive on the day of your surgery, you'll check in at the admissions area and go up to the preoperative area. You'll change into a gown, and the nurses and the doctors will come assess you. The nurse will put an IV in your arm, and then after that, when the operating room is ready for you, you'll be wheeled back. Most of our patients receive regional anesthesia, which is a nerve block in your spine, similar to the concept of an epidural, but it is a one-time dose of medication that makes you numb from the waist down. You'll also get IV medication to keep you asleep and comfortable for the whole procedure. Patients rarely require general anesthesia, which is anesthetic gases through a breathing tube. This is more heavy sedation. This will be used with certain medical conditions or if you are unable to have a spinal anesthesia. Another thing you will get for a total knee replacement is a femoral nerve block, which is a small tube that's placed in your thigh at the femoral nerve before the surgery to help keep your leg numb. The doctors and the nurses can change the amount of medication you're getting so that it creates the right amount of numbness in your leg. What kind of anesthesia you get is based on your medical and surgical history and will be reviewed with you at the prepare appointment. The final decision is up to you, the patient, as well as the anesthesiologist before the surgery. Recovery in the hospital. The surgery itself takes about an hour to 2 hours per side. Then you'll go to the recovery room for about 3 to 4 hours while the nurse will monitor your vital signs, make sure you're waking up comfortably after anesthesia, and monitor your pain. When you're fully recovered from surgery, you'll go up to the 12th floor the orthopedic floor. You'll be on the orthopedic floor for approximately 2 to 3 nights. Physical therapy will work with you starting the day after surgery. Occupational therapy will also work with you during your hospital stay. And nurse case managers will visit with you to discuss your needs. If you need to go to rehab or setting up any home care or ordering any equipment, they'll be happy to work with you on this. Pain. Knee replacement surgery is painful. We will give you sufficient pain medications, but we'll also maintain your safety. Oftentimes, the pharmacy pain team will visit with you in the hospital to discuss which pain medications are working well for you, as well as manage any side effects such as nausea. Pain and the pain scale. We will give you sufficient pain medication, but maintain your safety. We will ask you to rate your pain on a scale of 0 to 10. 0 means no pain, and 10 means the most pain you've ever had. Our goal is that your pain to be managed enough so that you can do your exercises. Don't wait to ask for pain medication. We don't want to chase your pain. We don't want you to become too uncomfortable. And the bottom line is that you're able to manage your pain so that you can do your exercises to have a successful knee replacement. There's a lot of things that we do to help manage your pain. You'll get a nerve block in your spine prior to the start of surgery, which lasts for about 8 hours and wears off slowly. You'll also have a nerve catheter in your thigh, which stays in for about 2 days. The doctors and nurses can change the amount of medication you get to provide more or less numbness. We also give you multimodal pain management, which is 3 separate oral medications which are given prior to the start of surgery and then continued for 2 weeks after the surgery while you're at home. These 3 separate medications are Tylenol or acetaminophen, which is a pain reliever, Celebrex, which is a brand name anti-inflammatory, Neurontin or gabapentin, which is a nerve pain medication. We will not give you any of these medications if you have an allergy to them or if there's a contraindication, a reason why we cannot give them to you. I want to spend a few minutes explaining this multimodal pain management. Tylenol or acetaminophen is a gentle pain reliever. Celebrex is a brand name anti-inflammatory, which helps reduce inflammation after surgery. No other medication exists like this at this point in time. This medication can be safely given around the time of surgery because it does not increase your bleeding risk. What is important for you to know is that many insurance companies require paperwork or the cost is very high for this medication. If this medication costs too much money for you to pay for, you do not need to take it and it will not change the outcome of your overall surgery. Neurontin or gabapentin is a nerve pain medication that helps with the pain at the incision site. We will also use narcotic pain medication, either Norco, Vicodin, Percocet, oxycodone, or Dilaudid, based on what you've tried before. This medication will be tailored to your needs and help you manage your pain. We do not routinely use a patient-controlled analgesia machine anymore, or a PCA, which is a bag of pain medication which is attached to your IV and you're allowed to push the button every 10 minutes. We've stopped using this because it causes a lot of nausea and vomiting post-operatively and can limit you in getting out of bed. Pain management. A lot of the narcotic pain medication has Tylenol or acetaminophen in it, or we'll be giving you a separate acetaminophen Tylenol pill. We don't want you to take any additional Tylenol because it can be harmful to your liver or kidneys. The maximum amount of Tylenol for most patients in 24 hours is 3,000 milligrams or 3 grams. Upon discharge from the hospital, you're going to be given a list of medications that you should take when you go home. Please stick to this list, and if you have any questions about it, please call our office. We will use ice to help manage your swelling and pain after surgery. While you're in the hospital, we will use this ice machine. However, once you get home, it is not important that you use this machine, but it is important that you do use ice. We recommend using ice packs or bags of ice to help reduce the pain and swelling. It is very important to ice, especially after physical activity or your physical therapy sessions. Please put a towel or a pillowcase between the ice pack and your knee so that you don't get an ice burn. We recommend icing for 20 minutes at a time. Also, don't fall asleep with the ice on your knee, as this can cause an ice burn on your knee. Constipation. Orthopedic surgery causes constipation because you're not moving around as much as you usually do. Also, narcotics can cause constipation. We will provide you with medication to keep you regular while in the hospital and then at home. The three medications that we typically use are Ducosate or Colase, and this is a red pill, which is a stool softener, Senna, which is a gentle laxative and is a brown pill, and Miralax, which is a powder that you add to a drink. All of these medications are over the counter. The important part to know is that please don't wait too many days before taking action. If you feel constipated, please call our office and we'll call in a more stronger prescription for you. If you feel that you do not need these medications, it's okay to not take them. Frequently asked questions around knee replacement. Patients often want to know when they can drive. You must be off all the narcotic pain medication and be able to make a quick decision with your right leg to start or stop the car. If an accident happens and you're on narcotic pain medication, it can result in a DUI. Patients often also want to know when they can return to work. It really depends on what your job is and your recovery time, but usually in a matter of weeks you'll be able to get back to work. Will I set off metal detectors? Yes, you should give yourself extra time at the airport. Choose the body scanner line if possible because they'll know that you have a knee replacement. Physical therapy. The first time you get out of bed, you may feel dizzy or lightheaded, and the reason for this is that you have anesthesia and pain medication in your body that you're not used to having. You've also been laying on your back for quite a long time. We want you to always call for help before getting out of bed. The nursing staff in the hospital is excellent at responding to the call lights and will be there to help you get up out of bed. Physical therapy will also work with you to make sure that you're able to walk with an assistive device, manage stairs, and teach you strengthening exercises. Shortly after you wake up from surgery, you'll find your leg in this position. This is to get your leg as straight as possible. We put a rolled towel or pillow underneath your ankle to try to get your leg as straight as possible. It's very important in your knee recovery surgery that you work on straightening your leg as much as possible as well as bending it. Discharge planning. All patients will get inpatient physical therapy, where a physical therapist comes to work with you in your hospital room and in the hallway for approximately a half an hour to an hour on a daily basis. They can work with you on doing stairs and making sure that you're able to use the assistive device correctly. From there's two choices. You may either go home after your 2 or 3 night hospital stay or to a rehab or skilled nursing facility. Most patients prefer to go home and are most comfortable at home. However, if there are a lot of stairs in your home or you have minimal support, rehab or skilled nursing facility may be best for you. If you do go home, there are two choices from there. Patients may either get in-home physical therapy, where a physical therapist comes to your house usually 2 or 3 times per week for a matter of weeks, or you may go directly to outpatient physical therapy, where you drive or take public transportation to an outpatient physical therapy location of your choice. You may go anywhere nearby to home that takes your insurance. And this will usually occur twice a week for about 6 weeks. Occupational therapy. The difference between occupational therapy and physical therapy is occupational therapy is more focused on your everyday tasks, such as getting dressed and bathing. These tools will be offered to you in the hospital, and you may take home whatever is helpful to you. The first item is a leg lifter. The second item is a long-handled sponge. The third item is a dressing stick, so it can help you get your pants off the ground. The fourth is a shoehorn, a long-handled shoehorn. The last one is a reacher, and the one to the right is a sock aid, which will help put your socks on independently. Occupational therapy will also visit with you during your hospital stay, and they'll help you with any of these items or logistics in taking care of yourself independently. Equipment. Everyone either gets a walker or crutches based on your preference and your physical therapy evaluation. It is important to know that if you've either gotten a walker or crutches in the last 5 years, sometimes insurance companies won't pay for a new set. Please have your support person bring it to the hospital on the day of discharge so that you'll be able to get from your car back into your home with an assistive device. If you've never received a walker or crutches before, one will be provided for you when you leave the hospital. The picture to the left is a 3-in-1 commode. This is optional and most patients don't need it. But if it is needed, it can be ordered from the hospital or purchased prior to discharge. It's called a 3-in-1 commode because it serves 3 purposes. If you leave the bucket on underneath the commode, it is a commode. If you take the bucket out and put it over your toilet seat, it's a toilet seat riser. Or if you put the top down and put it in the shower, it's a shower chair. Most patients don't need this, but if you feel you'll need it, it can be ordered ahead of time. We encourage our patients not to buy any equipment before surgery so we can see what you need, and an assessment can be done by the physical therapist, and then the caseworker can help order the things that you may need in the hospital. Fall prevention. We take fall prevention extremely seriously at UCSF. We need to prevent falls in the hospital as well as at home. We want you to always call for help before getting out of bed while in the hospital. This is imperative because patients may often feel that they're strong enough to get out of bed on their own. However, they may get dizzy when they stand up, or their legs may feel weaker than they expect them to. Some tips to prevent falls are we want you to be careful of the tubes, such as the oxygen or the IV tube that you may have for the first night. We want you to use the bathroom before it becomes an emergency. So if you're working with physical therapy and you're on your way back to bed, it's a good idea to use the bathroom on the way back to bed. Another thing you can do to prevent dizziness is to sit up as much as possible when in bed, so the change from lying to sitting standing isn't so great. We have a saying at UCSF called "Be a hero, get up on post-op day 0." Getting up within 2 to 6 hours of your surgery is beneficial because it decreases your risk of blood clots, improves your quality of life, and decreases your pain, as well as shortens your length of stay in the hospital. Your orthopedic nurse will usually be the one to get you up on the same day of your surgery, and you can get up anytime with the assistance of our staff, even if it's in the middle of the night. Please always call for help before getting out of bed. What counts as early ambulation? You and your nurse can decide about what's best for you based on how well you feel. But we want our patients to get out of bed and just stand up. You may march in place near the bed. You can sit out of bed for about 15 to 30 minutes, or if you feel like walking, you may do so with the assistance of our staff. Go ahead, try out your new joint. We know that there are barriers to getting out of bed quickly, and those may be pain or nausea or dizziness. Your healthcare team, including your doctors and nurses, will work on these issues to avoid delaying ambulation. We really want you to try to get up. You're still a hero even if you try. Please always call our staff before getting out of bed. Things you need to do in order to be able to go home. You need to be able to control your pain on oral pain medications. Get yourself in and out of bed. Walk the minimum distance in your home setting with using either a walker or crutches. If you have stairs in your home, you'll need to be able to demonstrate that you can do these safely. You or your helper will be able to inject the Lovenox blood thinning medication. We will talk about this in a few slides from now. Risks of surgery, we're going to go through these one by one. Infection, blood clot, nerve damage, loosening and wear. The good news is that each of these risks are less than a 1% chance. Preventing infection after surgery. We follow guidelines set forth by the American Academy of Orthopedic Surgeons. The recommendations for taking prophylactic antibiotics or preventative antibiotics before routine dental work or other invasive procedures has recently changed. The American Academy of Orthopedic Surgeons is now recommending that you discuss with your surgeon and care team whether or not they recommend taking antibiotics prior to dental work or other invasive procedures. We are no longer routinely recommending taking prophylactic antibiotics before dental work. However, you may discuss this with us in the office, as well as with the dentist. Incision care. You'll either have staples or sutures. We want you to keep the incision clean and dry until the staples or sutures are removed at approximately 2 weeks post-op. You do need to cover or seal the incision when you take a shower or just do sponge baths while you have the staples or sutures in for that first 2 weeks after surgery. Can recommend using plastic wrap or putting a bag and taping it over the incision to keep it dry while you're bathing. You will leave the hospital with a special dressing called a Mediplex. This should stay on for about 5 days. And it may have some saturation or drainage under the dressing, and this is normal. If after 5 days, or if it becomes more than 70% saturated with drainage, you should remove it and then use 4x4 gauze. You may use the 4x4 gauze and change it daily until the staples or sutures come out. This is what the 4x4 gauze will look like out of the package. You do not need to cover it any longer after the staples or sutures come out. Staple or suture removal. The staples or sutures are removed at approximately 2 weeks after your surgery, and they can be done in a variety of different ways. If you live locally, the nurse practitioner or physician assistant can remove the staples or sutures at UCSF Orthopedics at our Mission Bay office. If you have home physical therapy or nursing coming to your house, they can also remove the staples or sutures. If you go to a rehab facility and are there for at least 10 to 14 days, they can remove the staples or sutures there. If you live far away, you can have your local primary care provider take them out. If you are planning on having your local primary care provider remove the staples or sutures, you must set up this appointment for 10 to 14 days after your surgery. Incision care. If you plan on going home after the surgery, you will be responsible for changing the dressing once a day. However, the Mepilex dressing will stay on for about 5 days after your surgery, and then you should change the dressing once a day after that until the staples or sutures are removed. I do recommend 4x4 gauze and paper tape. So you'll need about 5 to 7 days or 5 to 7 pieces of gauze because the Mepilex dressing will stay on for the first 5 days after surgery. Some oozing from the wound is normal and it should be decreasing over time. Please do call our office if you have any concerns about increased pain, redness, swelling, warmth, or drainage from the incision. Post-operative swelling is normal. You may have swelling from your thigh to your toes. There's a lot of difference between patients with how much swelling you may have, and this swelling may last up to 6 weeks after your surgery. You may decrease the swelling by elevating your leg and using ice. Blood clots. This is another serious risk of having any surgery. Blood clots can form in the leg and move to the lungs or heart or brain, and we try very hard to prevent them. Signs and symptoms of a blood clot are pain in the calf that doesn't go away, a swollen calf, however this can also be normal, a ropey feeling under the calf where you may feel like a piece of rope is underneath your skin, redness in the calf, a fever, or shortness of breath. If you get shortness of breath and you're not exercising, you need to go to the emergency room or call 911. We try very hard to prevent blood clots, and we use a medication called enoxaparin or Lovenox, which is an injection for a total of 13 days after surgery. You'll get a dose in the hospital once a day for 3 days, and then you'll use 10 at home after surgery. This is an injection into the abdomen once every day. The nurses will teach you how to do this in the hospital. They will also give you a teaching kit from the hospital, which does not contain the medication, but it has a DVD in case you forget how to do it, a sharps box, and alcohol swabs. The medication will come pre-filled in a syringe and will look like this. You should get 10 of these after surgery. If you are already on a blood thinner of any sorts, we will potentially order a different kind of medication for you, and this will be discussed with your care team. We will also have sequential compression devices in the hospital, which are like little pillows that wrap around your legs and help squeeze the blood back up to your leg to the rest of your body. The best way to avoid a blood clot is to be active. We also encourage you to avoid flying for 6 weeks after surgery because this is the time that you're most likely to get a blood clot after surgery. Nerve damage is another potential complication of surgery. Sometimes patients complain that they have some numbness around the incision. This is generally temporary and improves over time. Foot drop is a more serious complication of the surgery, and that is the loss or the decreased ability to bend the ankle or the foot upwards. This is very rare that it happens, and if it does happen, it usually improves over time. Loosening or wear? On average, the implants last for about 15 years. What tends to wear out is the polyethylene liner. If that wears out, that may be changed as these pieces are modular. We encourage you to avoid high-impact activities like basketball or running, as this may decrease the life of the implant. We encourage you to find alternative non-impact and low-impact activities such as bike riding, swimming, or walking as part of your regular exercise. Preparing for surgery. Which medications you will need to stop or continue will be reviewed with you at your prepare anesthesia appointment. We would like you to stop taking medications that may increase your bleeding 7 days before surgery, such as over-the-counter anti-inflammatories like ibuprofen, Motrin or Advil, naproxen, or Aleve. You must also stop taking glucosamine, garlic, ginkgo biloba, ginseng supplement pills, vitamin E and fish oil, as these medications tend to thin your blood. You may continue to take Tylenol, Celebrex, or narcotics up until the day of surgery if you are already taking these. Preparing your body for surgery. You may increase the iron in your body prior to surgery. Sometimes patients like to start over-the-counter iron supplements. However, the best way to get iron in your body is to eat food rich in iron, such as green leafy vegetables, meat, or beans. Continue doing this for 1 month after your surgery. We also encourage you to maintain your current level of fitness between the time you decide to have surgery and your surgery date. What to bring to the hospital? Please bring a list of your medications on paper so that we can make sure that you receive the medications that you normally take at home. You may also bring books and magazines to keep you busy while you are resting. Also, wear a set of comfortable clothes and shoes to the hospital so that you may wear these either while doing your physical therapy in the hospital or on your way home. Don't bring your own medications to the hospital. The hospital will provide all of your medications that you normally take. Leave your cash and credit cards at home as well as your jewelry. We urge you not to bring too much to the hospital, as you will only be with us for a short period of time. Most of our patient rooms have large TVs in them, and you may also borrow laptops if needed. Please put your name and date of birth on all your personal belongings so that we can get it back to you if it becomes separated from you. Preparing your home for surgery. Remove anything that you can trip over. You may want to rearrange the furniture, such as pulling a coffee table out from the couch so that you have room to get through with either your walker or crutches. You may feel like having prepared food at home that can be easily available, such as microwavable food, or some things that are easy to get to. Please make sure you have a ride home from the hospital and someone to help pick up your medication. Sometimes pharmacies deliver. This may be helpful to you in your recovery. Preparing for surgery. We would like you to take a shower using a special soap called Hibiclens. This special soap will be given to you in the clinic, and instructions will be included on how to use it. We would like you to take 3 washes starting 3 days before surgery and wash daily, including the day of surgery. Please wash your body with it from the neck down. Avoid putting it on your face or genitals, and do not put on any lotions or deodorants after taking your shower. It is also imperative that you stop eating and drinking the midnight before your surgery. It's a good idea to review your surgery information and take any routine medications with a sip of water as instructed by our Prepare staff. Contact phone numbers. Please call our clinic anytime if you have any questions. We want you to have a very successful recovery, and we're here to help you if you have any questions. When you do call, please leave your name, your phone number, and date of birth every time you call so we can get back to you in a timely manner. After hours, weekends, and holidays, please call the answering service if you have an urgent orthopedic issue that cannot wait till the next business day. That phone number is 415-353-2808. If you have an urgent issue that requires immediate attention, you can call this number and ask to be connected with the orthopedic surgeon on call. He or she may help you answer your questions if it is an emergency after hours. Prescription instructions. Upon discharge from the hospital, you'll be given a prescription for the pain medication you had been using in the hospital on a special piece of paper. This special piece of paper is called a triplicate. You will need to stop on your way home and have this medication filled at the pharmacy of your choice. When you need a refill of this pain medication, please call our office with at least 4 days advance notice, as these medications cannot often be called or faxed into the pharmacy. We will be able to mail you the paper prescription to your house, or you can pick it up from our Mission Bay office. It's very important that you call us with at least 4 days advance notice if you need a refill to be mailed to you, as this is how long the mail often takes. Thank you for choosing UCSF for your total knee replacement. We are enthusiastic to work with you, and we are excited for you to get back to the things that you have been unable to do due to your knee pain. If you have any questions regarding the content in this video, please call 415-353-2808. We'll be happy to help you.